Hi, everyone. Welcome to another episode of the Inchstones podcast. Today I have Chelsea Willie, Dr. Chelsea Willie, here with me today. Chelsea and I had our lives converge at a conference for public speaking. And while our worlds are vastly different in the communities that we serve, Chelsea and I connected because we really lean into our most authentic selves and helping the communities that we serve. Chelsea is specifically a pediatric anesthesiologist. And Chelsea, just thank you so much for being here today and for providing context, because a lot of families like mine with neurodivergent children, we're in and out of doctor's offices all the time. Therapies, physicians, neurology appointments. You would probably be someone and have been someone in your exact field that has dealt with my children, whether it's general surgery for cavity fillings or for other operations. So what would be your directive and maybe pinpoint of like what you feel like is a great thing to talk with parents about?
Yeah, I think so. I work in two environments. I work both in the operating room and I'm also an intensivist. I work in the ICU when your child is also very sick. And I think in the OR setting, we do a lot, like you said, a lot of basic things that you would not sedate children for normally, right? You wouldn't sedate children to do dental time. But I think the first thing what we've done where I work is we actually use child life a lot. And I think that it is great
Yes.
to already talk to someone before you come in, because you are changing their pattern for the day. And we as providers have to understand that too. This is not what Johnny thought he was getting up to do today. Johnny is used to getting up, getting breakfast, going to school. And especially a neurodivergent child, when you change their pattern, it's a different feel. And I think that's the first thing we do, that we already have. I can look up the night before. I have something in my chart that says, this is what makes this particular child click. This is what that child doesn't like. So I think that wherever you may be, if there can be some kind of system or some way to get that across to the provider who you're going to meet, it just makes it easier. I know to keep the lights off. I know what questions to ask. I know the stuffed animal already, right? I don't have to figure all that out in the 10 to 15 minutes that I have to do a pre-op. And I think that really helps. I know that person doesn't like to be touched in this way, or I also know how they can communicate. Like I know that they are able to do A, B, or C. I think it also helps me feel comfortable and helps you as a parent feel comfortable when that information has already been discussed and I already know it when I walk into a room, because I'm a stranger. And I think that that's the piece that's important.
So, child life specialists aren't necessarily part of the process for other different medical, things. Specifically, my children who've done a few sedation dentistry procedures, it's so routine that like the whole process is pretty quick, but it's also so quick that it's like shocking so that we can like get this done and be out and be there. Would you ever suggest that parents, rehearse or practice kind of like those few things to tell, in that pre-op situation of like, hey, just a reminder, because if they don't get the whole chart, on a child, I always wonder what's overstepping my sharing and what's me just being a proactive parent, because my children express differently. They're both nonverbal, but I say, historically XYZ has happened. This is what they like. Thank you for caring for them.
Yeah, I think you make a good point. And I, as a provider, sometimes I'll just say, what can make this day easier for you? And then you can tell me that. Like and I don't think that's overstepping to say, these are the top 3 things. I don't need your whole 10-year history. I love to know, and I will say, when you came here before, were there any issues? I need to know that. I think that's not overstepping. And maybe today's a different day. It may go fine. And I think that's okay. But I think it's totally fine to say, this happened. This is what I did not like. This is what he or she did not like. And I think that is not overstepping bounds, because you are the person that's an advocate. And I think I don't care who, if a medical provider you're working with can't understand that, they probably shouldn't be doing pediatrics, right? The parent is an advocate. Is a parent difficult for us sometimes? Absolutely. But it also has to be a mutual understanding that I'm here to take the best care of your child. I don't think it's overstepping boundaries to say these are the things, but I think it's a way to say it and say, this may not be how this experience goes today, but in the past, this is what has happened. And I think that is helpful.
That's huge. Leaving room for the possibility that we might be smooth sailing today and it's, completely fine. I'm sure you know that parents in my situation have had medical situations be, like you said, sometimes it's smooth, sometimes it's a complete dumpster fire, for lack of a better term,
Right.
of like physically restrain, helping nurses physically restrain. And it's a bucket of mild trauma that we have to intake all the time. Right. And first of all, thank you for how you care for your patients and their families, because I just want to run and get every procedure done with you on my team for them right now. Like, I just go to Wisconsin. We
Come
get
on
everything done in
over.
Wisconsin. Yeah, exactly. But but I think, it takes a lot of emotional intelligence from the parent to not feel like it's rigid, right? And that there has to be a certain way of things that will take place in a medical situation. How do you feel that neurodiversity has been discussed more in your practice?
Well, we have a whole program for it now. It's actually it was a study to see whether it made a difference in some of the things that we did, and now it is a protocol. And it's a phone call
Wow.
that's made by our pre-op team, and this is what we do, right? And I think there's actually a spot, I wish I could show it to you, a spot in my chart that gives me specific information, and that is a neurodivergent child before you even open the chart. So I think that piece is super helpful. And I know, even my child life specialist, there's certain people, they will have requests certain of us. I'm a pediatrician first. That's what I trained as. And I did not train as the anesthesiologist. So my viewpoint is different, and I've gone through different training. And so I'm probably going to push the limits a little bit. I don't typically bring parents back. I won't typically, oh, Sarah, you can come back.
Yeah.
But with a neurodivergent child, if it's going to help, I can do that. I can make that happen. I have when I was a fellow, I put a child to sleep with a dog. That is what that kid needed.
Oh,
They needed their guide dog, and we figured it out. You can make those things happen. But I think it takes, my biggest thing though, it's so hard to do the day of. If you walk in there and I'm not prepared, it throws my whole day off, and I don't have the time, because it does take extra time, which is why a lot of times a neurodivergent child, we try to put them first. So that way we get them in, get them going, and then they can come out and talk to you while the child is in the OR. You don't have to have the kid back where you're trying to focus on the child while you're trying to listen to post-op plans or whatever the plan is for the day. So those the kind of thing I think is super important. My biggest thing is preparation. I think if I don't know ahead of time, it just makes your day worse. It makes my day worse. It makes the child's days worse. It's just because it takes time.
Well, we almost have a marketing line there, because my children crave preparation, right? Like the day after Thanksgiving, we're going to be in New York City and going to the Rockettes. And we've been talking about that for weeks. Typical children like to know and prepare as well, but it's essential. So if you're preparing your child for it, prepare the team too, and go that one little extra step in terms of making sure that the file is up to date with your child's needs, wants, sensory specifics, because you're right. It's we don't want to have to speak it and shock a team in the moment. And I have to be honest, I've been guilty of that, where, in the dentistry area of x-rays and things like that, where I'm, whoa, we're not going to be able to handle that right now. And then it's attempted, and this is not going to be a wonderful experience. But good luck. Yeah, please try. Is there a straitjacket around here? Because I'm going to have to help with the arms and limbs flailing.
I'll tell you something I learned from an attending when I was training that I've actually told this story a lot, that we brought a child. It was actually a young adult, this person, because, you're going to be responsible for your child for time into adulthood. So this particular patient was 20, 21, something like that. And they had told this particular patient that he was coming for going to the dentist. And that patient, I showed up pre-op. That's not what the kid was there for. He was there for a surgery. And he couldn't understand why he had all of his clothes off in a gown to go to the dentist. And the point I learned from that attending that day, he's like, I'm going to have to cancel this case. I cannot, as a physician, you have not been truthful with this child, young adult. And what a learning point for me, because you don't like to cancel cases, but to say that this patient is not prepared and it's not fair to him, despite what his mental capacity is. To force him to do something and then to lose that trust. I thought that was such a beautiful way to handle it. He's like, we just can't do this today. And I thought it was such a great way to handle
ripple
that.
effect. That's a wonderful example. And I think that gives a lot of parents beautiful hope in the evolution of medicine and the inclusiveness of understanding neurodiverse children and individuals, is that, yes, they need their bodies, their minds, their ability to respond and their dyspraxia, they're unable to control, their limbs and such, all these inputs of a situation. And then you think going down the road, what if this procedure has to be done again?
Correct.
And so the standard that you're setting for what is expected, these kids, the ability, they have to fit into a world not meant for their mind and bodies, right? That's what's forced upon them. And when they're seen as full humans, it's such a level of deep respect for that patient. You're giving such respect to the difference of that patient and how their lived experiences. Because because their receptive language, I'm not sure if this patient spoke or not, but my children, their receptive language is 100%. They understand what's going on around them.
And
to
which
be
is
met with
such a great,
respect.
you're so right about that. And you would be a parent who would look at me, and I think it's appropriate to say, talk to my child, right? Like that's because that's important. Like in general, when I walk into a room, I actually don't even look at you. I actually walk into a room and I look at whoever the patient is and I talk to them first, like the parent's not there. Because they're the ones. Right. And I think the biggest thing that I do a lot of diversity work too. What is that we all want in life? We want to be seen. That's it.
Seen and
it's
heard.
Simple. And I think that's the piece that's so important, even for a neurodivergent child who I know is not going to speak back to me and may cry, but I have focused on them. Or tell me about, you have a teddy bear. How amazing. Amazing.
Yeah.
And it's the same thing do with any kid. Like yesterday, this child wasn't even neurodivergent, but the child who's anxious takes a lot more time, but it's a lot more gaining that trust with that child to get them back.
My daughter, Millie, is a little more advanced on her device than my son is. She uses a mini iPad as a talker, an AAC device. And we were at the dentist and she brings it with her everywhere. She labels things, she talks. And when we went recently to doctor's office, it was in a dentist chair and she sat down and she went scared. And even though she's been there over and over again, and I said, look up on the ceiling, and they had put her specific show. And then she was like, happy, scared. Right. So it's this evolution, and it's like, I'm able to see and understand. And then I do think that the practices and your practitioners, what you are able to get back from these children is, even in their nonverbal or their very limited verbal communication, is huge. And I hope that it gives you something back in return.
I think
that's really important.
That's such a great piece. It's funny. I just was with a bunch of physicians on Friday and I said, they're like, gosh, I couldn't do pediatrics. I said, but the beauty of pediatrics is look what a child can do. I go, adults, they'd be a whiny mess. I go, what these children can do and the resilience, that's the piece that brings you back to work the next day. Right. You're doing it for that child. It's so funny. I had a same kid with the name yesterday, and we said how Millie was and it was a God-given name. Like that was a name that it wasn't like short for anything. I was like, oh my gosh, but it's like funny. It's a hard case, but you're doing it for that kid because that kid is it's amazing to see what they look like on the other end. They're amazing.
Yeah.
Way better
oh my
than
gosh.
me.
I mean, my younger two, specifically my Millie, like, gosh, my tween, I would hear about, there would be weeks of complaining and frustration about like, I can't believe you made me do blah, blah. Meanwhile, Millie does something, she gets through it and she gets home, hands you the remote control, like, put on my show so we can move on now.
It's amazing.
I always say it's like the best way of living is that like she just rolls with life and things beat off of her, even though she might feel more intensely or more sensory explicit in the short term.
Absolutely.
Is there any other directive that you would like to share with parents, specifically ones with non-speaking autistic children, about your profession and how to accept the beautiful gifts that you're providing to our children and to take that anxiety away?
I think sometimes the options we have is what we have. And I usually say I can either do this or I can do this because there's limitations. And I think understanding that I'm not coming to work to make you have a crappy day. My big thing is safety first. Safety for your child, safety for the healthcare team. Because as you mentioned, there's some children, there's different spectrums of what, especially when kids get
every
bigger.
Child different.
It's and I have to make sure that I'm safe and that I can, I can't have a kid falling off a bed or whatever else is going on. So I think just being a little patient with, and we're all going to have different styles. I'm pretty straightforward. That's who I am. I will also tell you a joke.
But you're so warm.
Figure out.
You're so
it is.
Warm.
I'll figure out what works for you. I'll know which parent the joke works for and doesn't work for you. We're all a little bit different, and know that I'm the different person that you maybe had the last time. So we all have a different way of doing things, and it doesn't mean it's wrong. right? It's different, and you still may have a similar result, or it's not a great result. And now we know that doesn't work, right? And we make note of that, and we say this was we've learned from it, and we move on. But I think that that's the piece that is being patient, that I may do things differently, or you're coming to a different institution where our way of doing things, we pre-med, whereas the other place did not. That's a different feel. And you mentioned not everyone has child life. Not everyone has music therapy. Not everyone has therapy dogs. I have all that here at the hospital where I am, and we can work with that. But you don't always have those pieces. But I think I always go back to safety, because that's really what matters. It may not mean I'm giving your child a great day, but I need to give your child a safe day to get through A, B, or C. Or if I'm in the ICU, I have to keep them safe. I can't have them pulling tubes out or doing A, B, or C. To the best of my ability, right? And I don't want to strap every child down if I don't have to. But we have how we work within the guidelines to keep your child safe, to get them through whatever it may be they need to get through. I think that's the part that I try to, no matter where I am, to come back to that piece. And I'm someone who doesn't have a child. And so they'll ask me, well, if it were your kid, well, if it were my kid, this is what I would do, or this would be the same way I would do A, B, or C. But I still care about your kid. I look at every child. This is the last one thing I would say. I don't care who you are, what your kid has. I treat your child as if they're mine, and I take the best care of them, because you're giving me your precious piece. You don't know me. And that's what you're doing. That's your most most valuable thing that you're giving me for that time. And I'm going to take your baby, and you're going to cry, and that's okay. But I'm taking Johnny. We're going to go do this now. And that's what I do. It's not that I'm being mean, but we got to get everyone through this.
I think that last portion that you just spoke to is something that parents that listen here could listen to before every doctor's office visit, every routine visit, because I know what I'm taking from that is such a reminder of the space that I can hold for the practice of the medicine that's going to be provided for my child. Because there's always such heightened emotions around procedures, specifically with, children on the spectrum and their reactions. And if we can just take a beat, right? Just hold space for the fact and remind ourselves that we're all in this for the safety and health of the child, and give that benefit to the practitioner. Because I think as someone that's in and out of offices and therapy rooms and all this literally every week, all week, sometimes we forget to give that space back to the practitioners too, right? Because we're so flooded with choices and navigating and this and that, what the next thing is, that we can forget to keep holding space for what you're saying is you're doing the best thing for the safety and health of the child. I mean, we'd all be so lucky to have you as a pediatrician. We'd all be so lucky.
Thank you. I have a good time.
You do. We're all, if the goal of a woman in life is to find her purpose and give back to the community, you have done it. And it is so, thank you so much for, giving us time today. And I think that what you shared is going to resonate within so many parents of children with neurodiversity and approaching situations in the medical community. So thank you.
Absolutely. Happy to help.
All right. Well, until next time on the Inchstones podcast, thanks, Dr. Willie.
You're welcome.